A 35-year-old male patient presented with headache. I'm showing you multiple brain MRI slices. Describe the findings.
All right, let's take a look. The selected brain MR images demonstrate a clear abnormal hyperintensity in the right transverse sinus on T1 and T2 weighted sequences. This hyperintensity is accompanied by a complete absence of the expected normal venous sinus flow voids. Additionally, there is abnormal high T2 and intermediate T1 signal within the right mastoid air cells. These findings indicate mastoiditis, which serves as the primary infectious source for the sinus thrombosis.
I am showing you an axial brain CT scan and a coronal CT venogram. What do they demonstrate?
The axial CT demonstrates a focal area of low attenuation involving both the cortical gray and subcortical white matter. The distribution of this low attenuation does not conform to any single arterial vascular territory, which is characteristic of a venous infarct. The coronal reformatted CT venogram demonstrates a clear filling defect within the left transverse sinus, illustrating the empty delta sign.
What is the diagnosis? Discuss the etiology, clinical features, and common locations of this condition.
The diagnosis is dural venous sinus thrombosis secondary to acute mastoiditis. The etiology is multifactorial, including local infection, head trauma, pregnancy, oral contraceptives, and inherited hypercoagulable states. Clinical presentation is notoriously nonspecific, often delaying diagnosis. It features headaches, nausea, vomiting, seizures, and progressive drowsiness. The superior sagittal sinus is the most common site of thrombosis, followed closely by the transverse and sigmoid sinuses. Mastoiditis predisposes to adjacent transverse or sigmoid sinus thrombosis due to direct inflammatory extension through the bony walls.
Explain the evolution of thrombus signal intensity on MRI and how it can lead to diagnostic pitfalls.
In the acute phase, the thrombus is isointense on T1 and hypointense on T2 weighted images, which can be easily mistaken for a normal flow void. In the subacute phase, the accumulation of methemoglobin causes the thrombus to appear bright on both T1 and T2 sequences. To avoid diagnostic pitfalls, phase contrast MR venography or CT venography should be performed to directly demonstrate flow absence or filling defects. Venous infarcts are frequently hemorrhagic, and detecting them outside arterial boundaries is a key diagnostic clue.
How would you manage this patient as a radiologist?
As a radiologist, I would immediately review the scan for complications, such as venous hemorrhage, midline shift, or signs of elevated intracranial pressure. I would issue an urgent critical finding notification to the referring physician due to the high risk of rapid clinical deterioration. I would recommend initiating immediate anticoagulation, typically with heparin, which is the primary treatment even in the presence of venous hemorrhage. Additionally, I would recommend urgent ENT consultation and intravenous antibiotics to address the underlying mastoiditis.